surveillance definitions. Now, clinical definitions are used for the purpose of treating the patient. Surveillance definitions primarily use ventilator-associated events, and they are majorly used for benchmarking and reporting purposes. So, briefly, definitions. Hospital-acquired pneumonia is that occurs more than 48 hours after hospital admission and not incubating at the time of admission. Ventilator-associated pneumonia is the pneumonia that develops more than 48 hours after ET intubation and initiation of mechanical ventilation. Ventilator-associated tracheobronchitis is patient with infection of the tracheobronchial tree, presence with fever, purulent secretions, even a positive culture without a new pulmonary infiltrate on the radiology. And ventilator-associated events, like I told you, are used for surveillance purposes, have been given by CDC, and they are not synonymous with the clinical definition of ventilator-associated pneumonia. So why is it difficult to diagnose? Because there is no perfect gold standard. Patients may have fever, leukocytosis, infiltrates, and even secretions because these are common things in the ICU. Radiology, X-ray has specific and limited sensitivity and specificity. Patient may even have atelectasis, ARDS, or even edema. So you should be able to differentiate. Cultures can be misleading because ET aspirates often grow colonizers, and oxygen requirement increasing PF ratios may worsen even in patients with fluid overload, collapse, embolism, or ARDS. So it should be a diagnosis is a probability judgment, and you treat the patient as a whole, not a single culture and not just a chest X-ray. So when do you clinically suspect? You walk into the ICU in the morning, and on rounds your staff tells you that they are noticing that there is an increase in the secretions. You look at the patient and you see that the patient's ventilate. There's a lot of asynchrony. The PF ratio is rising on the ventilator. The patient has developed a fever today. The counts are showing an increasing trend. The biomarkers are showing an increasing trend. And then you look at the X-ray and you see that there is a new infiltrate or a new consolidation that the patient has developed. So these are the clinical bedside suspicion parameters. And when you send in the microbiology, if you're sending the ET aspirates, you should be able to correlate it and rule out colonizers specifically. BAL, of course, becomes more specific, but then it has to be clinically correlated in all patients. A brief about pathogenesis. So we know that there is a risk of a lot of colonization. It starts right from the level of oropharynx, gastric contents, poor hand hygiene practices, and of course the immediate environment of the patient. Risk of microaspiration because of increased secretions, leak around the cough, and the ET tube having a formation of biofilm which acts as a microbial reservoir. Then these patients are usually in supine position, they're nursed in supine position, they're often given sedation, they may have a weak cough reflex. So all of this would lead to inflammation, increased purulence, impaired gas exchange, and respiratory failure. Similarly, for hospital-acquired pneumonia, risk factors can start right from the host being vulnerable to patients with risk of aspiration, the hospital flora per se, and failure of clearance of secretions by the individual. So, HAP prevention includes oral care, mobilization, dysphagia precautions, and avoiding unnecessarily antibiotics and devices, especially when they are not needed. So, what are the risk factors for both ventilator as well as hospital-acquired pneumonias? Ventilator-related patient has been in prolonged duration of mechanical ventilation, on tracheostomy, you've re-intubated the patient. Overall, the host is an elderly individual with a long-standing COPD, structural lung disease like bronchiectasis, malnourished, diabetic, CKD patient, or those who are immunocompromised hosts. Then, patient has been in a for a prolonged stay in the hospital or has had prior ICU admission, recent antibiotics, invasive devices, nursed in supine position, enteral feeding intolerance, sedation and dysphagia can lead to risk of aspiration. And of course, at the level of implementation as well, poor hand hygiene practices, cuff pressures are not checked daily. and the audits are not done properly. So these are also important aspects, especially in cases of prevention, and they pose as risk factors. So when we look at risk factors for MDR infections, which are again very prevalent and common in Indian ICUs, what is an MDR infection? When the microorganism is not susceptible to at least one agent in three antimicrobial categories. What is an XDR? When the microorganism is not susceptible to most of the antibiotics, but maybe one or two antibiotics in one or two antibiotic classes. And pan drug resistant becomes when the microorganism is resistant to all the drugs in all the classes. Is it possible for you to recapitulate? And we see a lot of XDR, Acinetobacter,
You have to do blood test and all those
things. ESA, CRE, which was a lot of strike, as well as
you have to bring it that all those things, then only we are able to
give.
You get it done?
So what
you
are
have
the
to bring it
factors,
the blood test. What and all blood test you want?
From the school, they want the physical
24
fitness
hours in the last 30 days.
I don't know what
Blood test
Hospitalization
means
beyond
lot of
5
blood
days
tests
before
will be there.
pneumonia
You
onset.
ask them what
No
format they are using.
colonization with gram-negative
bring it.
MDR pseudomonas or MRSA. Patient in septic shock and ARDS. Patient on hemodialysis, or there is a high MDR carriage risk in the healthcare centers, as well as patients with structural lung disease, because they are at a higher risk of developing pseudomonas infections or history of prior pseudomonas isolation. So you have to remember these risk factors because you need to accordingly choose your empirical therapy in your patients when they develop
for my
the
son
infection.
college, no?
So in Indian ICUs, the MDR risk, you need to remember what you need to check.
They have
is
given any
unit
format?
specific antivirals. Stick to your
If they didn't give
specific
format, you have to do the
know your
basic standard
antivirals.
test.
Avoid
I'll
copy
write and give
question,
you.
low MDR,
If they are giving format according to that,
starting
I'll give.
constant for every
If they are not giving
ventilated
format, means I have to go according to me.
without
For that, I need a blood test.
relevance. Then delaying active therapy in patients who are in shock, and continuing combinations even after you've received your antibiotic susceptible therapy and not de-escalating appropriately if it is required. So what would your diagnostic workflow look like? You have a patient
blood
with a
group,
specific clinical syndrome, you look at the radiology, the oxygenation change, the imaging.
How he old?
And then you decide that you're suspecting a HAP or VAP. You stabilize the patient, take care of the airway circulation. Then appropriate
Then you have to do all these blood tests.
when the patient is very sick, do not delay therapy in order to send samples. Samples should be sent in all patients, but do not delay therapy just to send the samples.
Yes. Physical fitness means everything it is fine.
And ultrasound
Doctor, you
is
do
a
this
useful
blood
bedside
test here?
tool.
Here it is
CT,
not
if there is
possible now.
unclear diagnosis
If
or
you want tomorrow
complications,
morning, you can.
start empirical therapy, know whether there is an
Morning
MDR risk or not,
around
and
9,
assess
9:30 you
severity,
can
and
give.
then
You
review
tell to
right
pharmacy, he will call them. He won't do. He will call the people, those who are
So, a
coming.
word about imaging, like I said, chest X-ray is the first bedside
It
test
will
that
take
we
around
generally do for all
4-5
our
hours to
patients,
come the report.
and it gives you
By
an
evening
idea
you'll get
about
it.
what you're
Then
dealing
thereafter
with.
we can
It will
submit.
identify the new infiltrate, the consolidation,
go
if
to
there's a
college
mimic,
first.
it will
Thank
tell
you,
you about
doctor.
that. Lung ultrasound is very useful. It is readily available at bedside in most of the ICUs. You can quickly look at the bedside for consolidation, dynamic air bronchograms, pleural effusion, and you can subsequently do guided drainage as well. But it is operator dependent, it is sensitive, and you have to correlate it. CT you only do when the diagnosis is uncertain, you're suspecting complications, or your mimics require specific exclusion. So in microbiology, we send blood cultures in all patients with severe infections, endotracheal aspirates in most of the ventilated patients, BAL and mini BAL, and pleural fluid becomes specific for source control in patients who present with it. So, when do you? What is the advantage of bronchoscopy versus non-bronchoscopic sampling? Remember, a non-bronchoscopic endotracheal aspirate or a mini valve is quick. It's easy. You send the sample quickly. So obviously, you will achieve the results early. But you need to remember that there is a risk of colonization, so you should be able to differentiate and correlate. Bronchoscopy is useful in patients who are immunocompromised and when there's a diagnostic uncertainty. It helps you to evaluate obstruction, bleeding, and other opportunistic infections. But you should avoid it if the patient is hypoxemic or is hemodynamically unstable. A word about rapid diagnostics and multiplex PCR. We all know that they help us to get rapid diagnosis and start early target therapy early. But you need to remember that you should be able to differentiate the possibility of colonization as well. Always send culture and antibiotic susceptibility testing in all the patients in whom you are sending your rapid diagnostics or multiplex PCR.
ಡ್ಯಾಮೇಜ್ ಆಗಿದ್ದಾರೆ, ಇನ್ಫೆಕ್ಷನ್ ಆಗಿದ್ದಾರೆ, ಅದು ಹಲ್ ಡಾಕ್ಟರ್ ನೋಡಬೇಕು.
Then how do you differentiate colonization versus true infection? If you receive a culture sensitivity report, your patient is improving and there are multiple organisms, don't start changing antibiotics for each organism based on the culture sensitivity because they could all be colonizers. If your patient is getting better, you can continue or even de-escalate your regimen. Candida and enterococcus in your endotracheal aspirates rarely cause pneumonia. They're mostly colonizers. Pseudomonas and Acinetobacter again would require symptom plus imaging plus oxygen change, so it would require clinical coordination to rule out that it is whether true infection or a colonizer. And similarly, sterile citrate, if you send a pleural fluid or a lung tissue, so it has much stronger evidence. So you should treat and you should simultaneously achieve source control in these patients. We've talked enough about mimics to remember when you get a patient like this, even the mimics like atelectasis, mucus plug, pulmonary edema, ARDS, pulmonary embolism, diffuse alveolar hemorrhage, as well as drug pneumonitis. You must remember this before just tagging your patient as hospital-acquired or ventilator-associated pneumonia, because the patient may actually have any of these and not a true infection. So what does your empirical therapy look like? How do you plan? So empirical therapy is obviously you've confirmed the clinical syndrome, you assess the MDR risk based on the risk factors that we just talked about, then you choose the right drug, gram-negative coverage, MRS says the risk factors are present, and anaerobic only when it is needed. Then you load, we've talked about this as well, always give full loading dose irrespective of the patient's renal function in critically ill patients, and you adjust based on the renal phenotype and in obese patients, and we review at 24 to 48 hours. So how would your empiric selection look like for an antibiotic in patients who do not have risk for MDR, bugs or pseudomonas? So in early non-severe HAP, generally a single active beta-lactam as per your local antibiogram is usually enough. Patients who develop HAP in ward with aspiration risk, so you do not add anaerobic cover unless you are suspecting the patient to have abscess, empyema and necrosis. Remember, in case of abscess and empyema, you need to achieve source control simultaneously, drain that empyema. Stable patient with low MRSA risk, avoid routine vancomycin linezolid cover. Stable patient with low pseudomonas risk, avoid anti-pseudomonal escalation if your local data supports. And how would your empiric selection look like in patients with MDR and pseudomonas risk? So prior ESBL and high ESBL unit, carbapenem may be justified in severe disease. Structural lung disease, like I said, there is an increased risk of pseudomonas or history of prior pseudomonas isolation, anti-pseudomonal beta-lactam based on prior AST testing. Then prior CRE or high CRE risk, so mechanism aware therapy, use carbapenem test and AST. Prior TRAB or outbreak, so you do not rely on empirical regimens. You distinguish in case of Acinetobacter colonization versus true ventilator-associated pneumonia. A patient who's in shock with MDR risk, you may start initial combination coverage as a short bridge until your antibiotic susceptibility testing is available, and then subsequently decide your final therapy and plan treatment. So I was just talking about combination therapy. You should use combination therapy briefly in patients who are in septic shock, have additional MDR, pseudomonas risk factors present, and you're awaiting your AST results. Avoid routine combination when the patient is stable without MDR risk. One active beta-lactam is confirmed. Toxicity risks outweigh the benefits. And combination, you just keep continuing even after you've received your AST. You need to de-escalate. You need to narrow down if your patient does not require that combination that you started as an empirical therapy. And cultures are, now showing you colonization, or you ruled out that this is a mimic. Even then, you should de-escalate. MRSA coverage is required for patients with prior MRSA colonization infections, severe necrotizing pneumonia, or post-influenza pattern, line or device source, or when there's a bacteremia concern, or there is a high MRSA prevalence in your unit and patient is presenting with severe HAP and VAP. Carbapenemase resistance, Enterobacter C. So these days, in most of the tertiary care setups, there is available tests for detecting the gene resistance. So if it is available, you should use it, send it, and if you get OXA48 positive, the drug of choice is ceftazidime avibactam. If NDM or NBL-CRE is positive, then astronam or avibactam strategy, or cefderichol, although not available in India. KPC-CRE, again, it is fortunately less common in the Indian ICUs. So again, ceftazidime avibactam remains the drug of choice. Meropenem, vivorbactam, imipenem, relebactam are again good choices, but they are not available in our country. Then difficult to treat Pseudomonas. If the Pseudomonas is susceptible to a traditional beta-lactam, then use an active anti-pseudomonal beta-lactam and optimize the dose. If you are dealing with a difficult to treat Pseudomonas, then ceftazidime avibactam or fosfomycin are good choices. Other combinations like ceftolozone, tazobactam, imipenem, relebactam, and cefderichol, if the isolate is susceptible,
We didn't allow any
not
contact or
available in
anything.
our country.
That skin doctor had said it can spread.
Then, a word about crab infections. Remember that when you have a resistant Acinetobacter,
cold, no citrus,
it
no
is
jam.
generally considered
Light
that
food you have.
Acinetobacter species
Sorry?
is
Light food you have to
inherently
give.
sensitive to
For
sulbactam.
him.
So the
No cold, no citrus, no
regimen
jam.
becomes
No
sulbactam
citrus
containing,
also.
which is the
Okay.
central. In our country,
No
we
jam.
use high dose anti-sulbactam
Citrus
based
completely
combinations. We would give
We have
minocycline, tetracycline to our patients.
lotion, calcium.
Polymyxins and colestins are also very widely used, but these days, because of the problem of toxicity, it is preferred that you use polymyxin sparing regimens and avoid using them as a
We can send
reflex.
them to school, right? No problem.
Sulbactam, durlobactam
wherever
is
effect agad
the combination of choice wherever available. A word about PKPD. We know that for beta-lactams, we give full loading dose in severe infections, and you do not modify loading dose based on the patient's renal function. Extended or prolonged infusions in critically ill patients, you adjust the maintenance based on the renal phenotype, and those who are obese or those with hypoalbuminemia. You monitor for drug toxicity and as well as response, and you review the patient based on MIC response toxicity, and if you can de-escalate. Inhaled antibiotics not used routinely, used only when MDR gram-negative pathogen with limited systemic options, and when it's only susceptible to colistin or aminoglycoside or very difficult to treat infection. So what does your early assessment look like? Your early assessment will be based on clinical parameters. Has your patient's fever started to subside? How's the work of breathing, function, demand, shock, implementation? What are the ventilator requirements? How the secretions responding? Then what are your cultures and your AST showing you? Do you need to modify treatment at this
For
point?
3 days.
What is your imaging trend
And
showing
this
you?
morning, if he has to take the tablet, he can have one glass of milk and have it, right?
Or is it
Because
persistent?
he doesn't eat anything in the morning before.
Accordingly, you decide
Our
based
school
on
breakfast
the patient's
ಅವ್ರಿಗೆ ಎರಡು ಡಬ್ಬ ಕಳಿಸ್ಬೇಕು.
duration.
Morning 10:30 on breakfast and 12:30 lunch.
What would your
In the morning we don't
comfort
feed him anything in the morning.
patient is improving, so you can start
Either
de-escalating
eats
or
one boiled
dialing
egg
down.
or one
And
glass of
you
milk.
can accordingly, modify your
Then he
treatment
can take
based
the
on the
tablet.
patient's response. And by this time, you would have your
Thank you,
culture and
doctor. 3
antibiotic
days
susceptibility
enough.
testing also available. If the patient is stable but still unclear, so at this point, you may have to check your sample quality. What kind of sample did you send? What is your imaging trend showing you? The biomarker trend. Are you dealing with something else? Is it not really an infection? Is your drug dosing appropriate or not? So just because your patient is stable, but things are not improving, don't automatically start escalating antibiotics. And the patient is worsening, then you broaden only if your coverage was inadequate. If you need to achieve some source control, which you did not do initially, are you now dealing with some complications or resistant pathogens. So it will all depend on the patient's underlying presentation. Duration of treatment. Uncomplicated HAP-VAP with good clinical response, usually 7 to 10 days is the adequate duration. For patients with Pseudomonas, Acinetobacter, MDR gram-negative HAP-VAP, generally 7 to 14 days, but do not prolong solely because the pathogen was a drug-resistant pathogen. With persistent fever, leukocytosis, worsening oxygenation, you reassess the diagnosis first. Look whether you've achieved source control or not. And are you dealing with resistance at this point? Individualized treatment and not generalizing, just escalation is worsening. Staph aureus bacteremia, more than 14, at least 14 days minimum for uncomplicated infections and 4 to 6 weeks if complicated. Infective endocarditis, usually 6 weeks or more, but this again becomes organism and valve specific. Empyema, remember source control. You need to drain that empyema, and 2 to 6 weeks, again guided by source control and response. For patients with metastatic infection, necrotizing pneumonia, lung abscess, typically 3 to 8 weeks. And of course, it is site specific and radiology guided. Biomarkers useful as not as the decision makers for choosing the empirical therapy or deciding on your antibiotic therapy, but for de-escalation and maybe for assessing response. So do not use PCT or CRP alone based on the trend, the value, and don't use one single value. Use trend for these biomarkers, both procalcitonin as well as for CRP, and it would depend upon the clinical response, the microbiology, imaging, source control. So it has to be an integrated process, not just getting one value of procalcitonin and escalating or de-escalating your therapy. Don't do that. So what would the prevention look like? The patient has been in the hospital. If you implement good practices, you might prevent that infection from developing. So you have to have simple evidence-based practices. You need to train and educate your staff. You need to have proper surveillance systems in place, audit what you've implemented, and then have a proper feedback system to understand whether the implementation has actually taken place and is it actually helping in prevention of these infections from occurring. So we know that every surface in the ICU, whether the bed rail, the monitor, or the doorknob, can harbor organisms that no antibiotic can kill. So you must disinfect surfaces every 8 to 12 hours in an active ICU and not just once daily. So this has to be implemented. This has to be taught to your staff. And environmental decontamination, priority services, surfaces that I just talked about, terminal cleaning after discharge, transfer of the isolation rooms, and enhanced technology like UVC and hydrogen peroxide vapor. Yes, they may support terminal disinfection, but it does not replace manual cleaning. So you need to have decontamination practices in place, clean, disinfect, audit, and have a proper feedback mechanism in place. Do not blame resistance only on antibiotics because contaminated environments can sustain transmission. So, what are the everyday items that you look at for prevention? Hand hygiene, very important because hand hygiene in itself is one of the most powerful intervention and it reduces MDR transmission by up to 50%. So, before coming in contact with the patient, before aseptic task, before after handling patient's body fluid, after patient contact, after touching patient surroundings. It is one of the most single and most powerful intervention if implemented properly and practiced every time. You must reassess your patients daily for extubation. So spontaneous breathing trial, if there is no contraindication, should be given to the patient daily. And you must assess the patient's mentation, whether he'll be able to protect his your patient to be intubated for beyond 48 to 72 hours. Use tube with subglottic secretion drainage port because we use usually those for endotracheal as well as for tracheostomy tubes in our ICUs. Then you remember that you must minimize the duration of mechanical ventilation. It is important. Avoid re-intubation Don't be in a hurry to extubate your patient. Check if the patient requires HFNC or NIV post extubation. Then, oral care. It should be again emphasized upon. Do not rely only on chlorhexidine as a routine universal VAP prevention solution, because oral hygiene can be mouth because can become a reservoir for aspiration, dental plaques, and poor oral hygiene increase the pathogen burden. So you need to implement this. You need to teach your staff. You need to emphasize upon it daily and check whether they are doing it properly or not. Then positioning and mobilization. Nurse your patient in 30 to 45 degrees head end elevation. Mobilize your patients daily if there is no contraindication. Suctioning should be brief, and you should avoid routine saline lavage because it increases the risk of contamination, as well as in hypoxemic patients, it just worsens the oxygenation. Humidification should always be maintained. A lot of times, the nursing staff will remove the HME filter for nebulizing and then forget. So you have to emphasize, teach your staff to put it back once they've nebulized. And physiotherapy should be targeted. It should not be a routine ritual. Selective digestive decontamination is good in places where the local AMR burden is low and surveillance is strong. In Indian ICUs and our setups with the high AMR burden, we don't practice selective digestive decontamination anymore. Not advisable as a routine VAP prevention, routine oral chlorhexidine, circuit changes unless they are soiled or they are malfunctioning, kinetic beds prone solely to prevent VAP, routine stress ulcer prophylaxis, routine gastric residual monitoring, and early parenteral nutrition. What you should not do: do not diagnose swab from culture alone. Do not overuse carbapenem and colistin because we have high antimicrobial resistance. Do not forget source control. Just cultures and antibiotics is not going to treat your patient if you don't achieve that source control. And do not continue beyond 48 to 72 hours when you can see that the patient is getting better, your AST is showing you appropriate results, which is telling you that you can de-escalate. So to summarize, diagnosis is a probability of happen VAP, so do not treat culture, chest X-ray or fever alone. MDR risk must be explicit. You need to remember your MDR risk factors before initiating patient or empirical treatment. Dose matters. Always give full loading dose for beta-lactams and prolonged or extended infusions in critically ill, and modify based on the renal phenotype and obese patients. Reassess early at 48 to 72 hours, and prevention is daily work. So head and elevation, oral care, cough, spontaneous breathing trial, mobility, circuit discipline, surveillance, and having a feedback system in place always matter. Thank you.
Thank you, Dr. Kansha, for giving a wonderful presentation on HAP and WAP. And now we start the today's proceeding. And I have a great pleasure in inviting Dr. Tanu Singhal, who is MD Pediatrics, and he is an expert in infectious diseases. She practices as a consultant pediatrics and infectious disease specialist at Kokila Dhirubhai Ambani Hospital, Mumbai. She has more than 110 publications in index journals, and I have seen her lecturing. She gives very good lectures whenever I have the privilege of hearing her. So over to you, Dr. Tanu, to conduct today's proceedings.
Thank you, Dr. Chawla, for inviting me, to moderate this important session on gram-positive infections. I think, gram-negative infections are more common in Indian ICUs as compared to gram-positive infections. But when you do see gram-positive infections, they can be very challenging to treat because there are so many other aspects that we have to take care of apart from antimicrobials like source control, etc. So I think without wasting any more time, let me invite our first speaker, Dr. Rohit, who is an infectious diseases consultant at Amrita Hospitals, Faridabad. He is basically quite qualified. He is antimicrobial stewardship program physician, and he's a member of the hospital infection control committee and infection control team. He has many publications, and his areas of interest include PUO, tuberculosis, and related infections, infections in immunocompromised patients, etc. And today he's going to be talking to us about, um, gram-positive infections. So, Dr. Rohit.
Thank you, ma'am. Thank you for this introduction, and I would like to thank Rajesh sir for giving me this opportunity. I will just start my presentation. Is my slides visible, sir?
Yes, they are visible.
Okay. So I would directly start with a case. It is a patient. He is a patient, 45 years male, who's a daily wage worker. Who lifts heavy objects, not a known immunocompromised person. He presented with complaints of pain in right thigh and knee joint for 2 weeks, difficulty in walking for 2 weeks. MRI was done, which showed features of myositis with septic arthritis. First aspiration was done, which showed gram stain, showed gram-positive foci. So how do we manage? So these are some of, this is one of the few such cases which we routinely see in our clinical practices, and there are certain questions which come to our mind when we see such kind of case. So the questions being, what is the likely pathogen in this case? What is the susceptibility pattern? What should be the choice of initial antibiotics until cultures are waited? And then when we get the culture report, what should be the targeted therapy? Should I go for a monotherapy or should I go for combination therapy? What should be the ideal duration of therapy? And are there additional any measures which needs to be taken care while we are managing such patients? So, in this presentation, the learning objectives will be participants at the end of this session should be able to understand the problem statement of gram-positive infections, identify or understand common gram-positive pathogens, their clinical syndromes which cause critical illnesses, understand and choose the appropriate management strategy, antimicrobial therapy for gram-positive infections in ICU settings. Gram-positive infection, it's an umbrella term for a multitude of pathogens, which can be gram-positive focus, for example, Staphylococcus aureus, Streptococcus species, cons, some gram-positive bacilli such as Corynebacterium, Clostridium, Bacillus species. And this includes this multiple clinical syndrome, which would be overlapping, like similar syndrome can be caused by different gram-positive pathogens, or they can have their own distinct clinical syndrome. For example, Clostridium tetani causing tetanus. So these are the leading causes of nosocomial infections. Globally and Western countries, it has been seen, as Madam was also emphasizing, that these are the leading cause of ICU infections globally. But in India, gram-negative infections are more of a concern compared to gram-positive infections. Why gram-positive infections are very important? Because these are the major causal drivers for prolonged antimicrobial therapy. Usually, the syndromes associated with gram-positive infection, they require prolonged antimicrobial use. They often use surgical, they often involve surgical interventions in form of major debridement surgeries, implant removals, and therefore they are associated with high morbidity and mortality. And because of this surgical interventions, multiple antibiotic, prolonged antibiotic use, prolonged hospital stay, there is increasing healthcare costs associated with these infections. So regarding gram-positive infection in India, so gram-positive infections are less compared to gram-negative infection. However, the burden is still very high. According to recent ICMR and WHO report, one key thing which needs to be emphasized is that major focus is on gram-positive focus. However, that is Staphylococcus species, Streptococcus species, Enterococcus species. And there's very less focus on other category of gram-positive infection, such as gram-positive bacilli, like Clostridium difficile, C. difficile infection. Regarding the burden of these gram-positive infections in the Indian scenario, Staphylococcus species account for 13.22% of all positive isolates. Most common site of isolation was bloodstream infection, which was 26%. And among these Staphylococcus isolate, it was the most common site. Methicillin resistance, the major resistance pattern for Staphylococcus species the prevalence of MR was around 50% according to this ICMR report. The other gram-positive pathogen, Streptococcus pneumoniae, the isolation rate is around 0.5% amongst all the isolate, and the most common site of isolation was superficial infections. Enterococcus species accounted for 6.7% of all isolates, and most common site of isolation was urinary as the main site of pathogenesis. And the predominant mechanism of resistance, the most important mechanism, that is vancomycin resistance, was seen in 70% of the Enterococcus isolates. So this is the ICMR report showing the percentages of different gram-positive coccus in the different isolates. So why gram-positive infection matters to us? So as I was mentioning earlier, the different gram-positive pathogens have ability to cause variety of clinical syndrome, which can be either a localized skin and soft tissue infection, which can be deep invasive infection, and sometimes acutely necrotizing, potentially fatal infections. Rising incidence, the other issue is the incidence of gram-positive infections has been rising globally as well as in our country. And the reasons are multiple, such as the increasing population of immunocompromised hosts due to hematological malignancies, use of chemotherapeutic agents, solid organ transplantation, stem cell transplantation. There has been a significant increase in the use of intravascular devices for hemodialysis or for chemotherapy ports. There is significant use of central venous catheters. Then sometimes there is use of ECMO, LVAD devices. So due to this significant intravascular access, there has been increase in the incidence of gram-positive infection. Use of orthopedic implants has been associated with increase in gram-positive infections. And then other reason being sometimes increased use of prophylactic and prolonged therapeutic antibiotics, which is also predisposed to development of gram-positive infections, mainly Enterococcus species. Now, the main concern for this gram-positive infections is the rising burden of resistant isolate. So, not just the incidence of this bacteria is increasing, the prevalence of the resistant isolate is increasing in this gram-positive infection population. And this is very important to understand or to know, because there is very limited arsenal to treat such kind of multi-drug resistant strains, which cause invasive syndromes. So this figure shows the landscape of gram-positive infections. So if based on gram staining efficacy, we can divide or categorize the gram-positive bacteria into mainly two categories, which is gram-positive bacilli, gram-positive rods, or gram-positive cocci. So most important gram-positive cocci are Staphylococcus species, Streptococcus species, and Enterococcus species. In these Staphylococcus species, the most common and most important pathogenic species is Staphylococcus aureus, and other coagulase negative species are known as coagulase negative Staphylococcus species. Amongst the Streptococcus, these are divided based on hemolysis into three categories: alpha, beta, and gamma hemolytic species. So alpha hemolysis category includes Viridian Streptococcus and Streptococcus pneumoniae. Pneumonia has already been discussed in community-acquired pneumonia previously. In species showing beta hemolysis, group A Streptococcus and group B Streptococcus species are most important clinically. And amongst the non-hemolytic species, fecal and non-fecal enterococcal bacteria are the most common pathogens. In the gram-positive rods, aerobic bacteria includes Listeria, which is one of the most common gram-positive rod clinically, followed by Bacillus corynebacterium species, and in the anaerobic category, it is Clostridium. So, a few words regarding the pathogenesis. So, pathogenesis of the gram-positive infections is mediated through the several virulence factors, which work to overcome the immune responses, overcome phagocytosis, or facilitate the intracellular survival of the bacteria. In some of the gram-positive bacteria, they have additional toxin-mediated mechanism of pathogenesis, which can be exotoxins or enterotoxins. So, some of the key toxins produced by these gram-positive bacteria include enterotoxin or toxic shock syndrome toxin produced by Staphylococcus, pyrogen toxin produced by Streptococcus pyogenes species, diphtheria toxin produced by Corynebacterium bacteria, anthrax toxin produced by Bacillus anthracis, and so on.
कब से ऐसा?
So, few words regarding AMR in this gram-positive infections. So, most common gram-positive infections or pathogens in this category include Staphylococcus species, Enterococcus species, and Streptococcus species.
बुखार कुछ आया था?
AMR, there has been a rising incidence of antimicrobial resistance in Staphylococcus aureus. Most important determinant is methicillin resistance. So methicillin resistance is acquired due to acquisition of a MAC gene on the mobile genetic element known as SCC, staphylococcal chromosomal acid. So due to this acquisition of this MAC gene, what happens is there is target modification of the penicillin binding protein from PBP to PBP2A. And due to this modification, the bacteria becomes resistant to all beta-lactams, that is all penicillins, all first 4 generation, that is first generation, second generation, third, fourth generation cephalosporins and carbapenems. So whole source of antimicrobial is lost due to acquisition of this MAC gene. MRSA has been categorized into community-acquired MRSA and hospital-acquired MRSA, which my next speaker will be covering. A hospital-acquired MRSA is important because it has also additional resistance to other class of antibiotics, not just beta-lactam antibiotics.
Allergic bronchitis.
Further, there have been new isolates which are now having reduced susceptibility to vancomycin or proplanin, which are known as glycopeptide intermediate sensitive Staph aureus or hetero-resistant vancomycin intermediate sensitive Staph aureus. So what happens is the genotypic mechanism of this is clearly not known, but what is happening is there is increased cell wall thickness, which leads to decreased cross-linking of peptidoglycans and increased proportion of DLR-DLR terminal. And due to this increased proportion of DLR-DLR terminal, there is increased sequestration of the glycopeptide molecule, and that is why it is not able to act on the cell wall synthesis process, and there is resistance. Now, regarding Enterococcus, the resistance to penicillin and ampicillin is due to overproduction of low affinity PBP, that is PBP5, penicillin binding protein 5. High level aminoglycoside resistance, it is there due to the presence of aminoglycoside modification enzymes, and vancomycin resistance in Enterococcus is due to excretion of VAN-A or VAN-B gene. And due to this, there is very limited antimicrobials with bactericidal activity. So, what are the scenarios? What are the clinical infections syndrome where we should suspect gram-positive infections into play? So the most common gram-positive infectious syndromes include bloodstream infections or infective endocarditis, community-acquired pneumonia, hospital-acquired pneumonia, ventilator-associated pneumonia, depending upon the regional or hospital prevalence. Skin and soft tissue infections are highly associated with gram-positive infections. Meningitis or intracranial abscesses. Most neurosurgical infections may be there due to gram-positive bacteria or CSF tract infections. Bone and joint infections are seen due to gram-positive bacteria. Surgical site infections, foreign body associated infections, including prostatic valve endocarditis, prostatic joint infection, cardiac implantable associated infections, left ventricular associated devices related infections, central line related bloodstream infections can be due to gram-positive bacteria. And sometimes sepsis of unknown origin. This can also be due to some certain gram-positive bacteria. So there are some few salient features regarding when to suspect gram-positive infections in community-acquired settings. So in a person presenting with severe community-acquired pneumonia, where we should what are the scenarios where we should suspect Staphylococcus aureus in a clinical consideration, so that empirical antimicrobial therapy should include coverage for Staph aureus. So if a patient has severe gap, so much severe that requires ICU admission, there is presence of necrotizing or cavitating infiltrates in chest radiograph or chest imaging, or there is empyema, or the pneumonia is following a influenza infection. And there are no risk factors for other kind of pathogens. For example, any Pseudomonas related specific risk factors. There is no risk of aspiration. So in this setting, Staphylococcus aureus should be suspected and appropriate antimicrobial therapy should be considered. Enterococcus bacteria is usually a human commensal pathogen in gastrointestinal tract, but due to overuse of certain antibiotics, which are selectively giving rise to the increased population of enterococcus, increased colonization of enterococcus, it can lead to invasive infections. So, in patients with intra-abdominal infection, enterococcus species can be considered for empirical coverage in patients with healthcare-associated infections, particularly post-operative cases, patients who are immunosuppressed, and these are doing antibiotics selectively, which are selecting out enterococcus, for example, cephalosporin. In acute pyogenic meningitis, community-acquired pyogenic meningitis, listeria should be considered in patients who are aged more than 60 years, in pregnancy, in immunocompromised states, patients with organ transplantation, malignancy, advanced HIV disease, diabetes, end-stage kidney disease, liver cirrhosis, or alcohol use disease. So coming to what are the antimicrobials which are used to treat gram-positive infections? So this is the figure which is showing collectively all the antimicrobials based on the gram scale. So right half of the figure is presenting the antimicrobials which are targeted on gram-negative bacteria. Left half is showing the antimicrobials which target gram-positive bacteria, and the drugs which are in the middle, they have spectrum towards both gram-positive and gram-negative bacteria. So, gram-positive antimicrobials include penicillins, anti-staphylococcal penicillins specifically, such as napcillin, dicloxacillin, flucloxacillin, MRSA-specific agents including vancomycin, clindamycin, doxycycline, trimethoprim, sulfamethocin. So it has both gram-negative activity as well.
On accident.
Linezolid, daptomycin, these are gram-positive specific agents. Then there have been certain new discovery of certain new antimicrobials which have been recently approved within India and outside India for treatment of resistant gram-positive infections, which include dalbavancin, telavancin, ceftaroline, ceftobiprole. So just I have summarized the list of those antimicrobials which have been approved for treatment of resistant gram-positive infections which are available in India. So foremost is levonoratitroxacin, brand name Ambrox. So it inhibits DNA gyrase synthesis.
Ointment and some medicine.
It is very important to know that levonoratitroxacin is available in both IV and oral formulation. IV formulation is important because levonoratitroxacin is supposed to be a bactericidal agent against this kind of gram-positive bacteria. And once a Staph aureus is methicillin resistant, levonoratitroxacin oral route is the only oral agent which has a bactericidal activity on Staph aureus. It has been approved for acute bacterial skin and soft tissue infections, diabetic foot bacteremia, and respiratory infections. Another is levonoratitroxacin. It is an oral product of levonoratitroxacin. Ceftaroline is a newer 5th generation cephalosporins which bind penicillin binding protein 2A, PBP2A, and it inhibits cell wall synthesis. It is also a bactericidal agent and it has a specific MRSA activity. So only cephalosporin or only beta-lactam which has an anti-MRSA activity is ceftaroline, or another 5th generation cephalosporin, that is ceftobiprole. Another newer agent is tedizolid, which is a protein synthesis inhibitor. It is a primarily bacteriostatic agent and it has activity against both MRSA and PRE infection bacteria. It has been approved for MRSA pneumonia, skin and soft tissue infections, and as a salvage therapy for MRSA bacteremia. Dalbavancin is another lipoglycopeptide which has been recently approved. It blocks peptidoglycan synthesis and therefore inhibits cell wall synthesis. It is a bactericidal drug and it has a very long half-life, and therefore it has a benefit for OPAT therapy to reduce the healthcare admission cost. Like patient can be shifted to dalbavancin and can be discharged and sent home, and they can be continued on dalbavancin as OPAT therapy. These are some of the other newer antimicrobials which have been approved for treatment of MRSA or resistant infection or resistant streptococcus infections, but these are not yet available in our country.
Is this the same gel?
This figure is just showing the spectrum of different newer antimicrobials. So as you can see, most of the newer antimicrobials have activity against most of the gram-positive bacteria, including MRSA, vancomycin-resistant Staph aureus, PRE, penicillin-resistant Streptococcus pneumoniae, as well as
I
cons.
think it is in my car. I will check with that.
Just few salient points about gram-positive antimicrobials. So there has been sometimes a confusion regarding ticoplanin and vancomycin, whether these are similar drugs, whether these are different drugs, whether one is better over the another. So essentially, clinical use regarding efficacy-wise, ticoplanin and vancomycin are similar to each other, except CNS infections, where due to poor penetration of ticoplanin, vancomycin is the preferred drug. And regarding safety profile, ticoplanin is lesser nephrotoxic compared to vancomycin, therefore it has a better safety profile. Daptomycin should not be used for treatment of pneumonia because pulmonary surfactant inactivates it, and therefore a bacteria, MRSA, any bacteria causing pneumonia, any gram-positive infection causing pneumonia, if we are using daptomycin, so it is not going to give any benefit because it is getting inactivated in the lungs. Ceftaroline is the only beta-lactam with reliable MRSA activity. Long-acting and glycopeptides, example dalbavancin, I have simplified outpatient treatment and used to reduce hospital stay. Levonorticloxacin is a newer anti-MRSA option, and it is an oral bactericidal drug for treatment of MRSA, so it's a very excellent choice for switch down option. Now, regarding management of gram-positive infection, the general principles of management remain same as we have been discussing in the previous modules in different clinical syndromes. So, first key question will be to disaggregate to decide whether it is a disease or it is an infection. Either is it just a colonization or contamination, just a positive culture without any clinical signs and symptoms, or there is a presence of disease. So, if there are any clinical history suggestive there are clinical signs, then it is likely that it is bacterial infection and antibiotic should be considered. The use of antimicrobial should be, the threshold should be lower to start empirical therapy, mainly in infections which are life-threatening, including septic shock, febrile neutropenia, or patients with bacterial meningitis. The choice of initial therapy depends, like it's a dictum I used to tell everyone, bug drug site combination. So we should know the site of involved site of what bugs, what bacteria are causing that particular syndrome, and then what drugs can be used to treat that bacteria as per the site involved. So that is something which we should keep in mind regarding the initial empirical choice. We should be knowing the community and hospital diagram for appropriate choice of empirical therapy. Few important key parameters which should be keep in mind is use of static versus cidal drugs. So drugs which are just inhibiting the growth of bacteria at physiologically achievable concentration. These are known as bacteriostatic drugs, and which inhibit as well as kill the growth of completely kill the bacteria, known as cidal drugs. So in patients with serious life-threatening infections, immunosuppressed hosts, or infections of vital tissue, it is preferred that we give cidal therapy, cidal drugs over static drugs. And then obviously based on PK parameters, depending upon patient's weight, body weight, other parameters such as CRR, peritoneal dialysis, ECMO, renal functions, we modify the dosage. We give the particular drug as infusion, or we give the loading dose followed by the maintenance dose as per renal clearance. Then de-escalate early as the culture reports are available. And source control, it is one of the very key important interventions with respect to gram-positive infection, because unless there is adequate source control, unless there is removal of the focus from where the infection started, the patient is not going to, or the clinical condition is not going to improve. So just I will be discussing few cases. If somebody wants to give certain suggestions, can put in the chat box. So this is the first case that I started with. So 45-year male daily wage worker.
5 minutes. 5 minutes.
Sure, ma'am. I'll complete, ma'am. Thank you. 45 years male daily wage worker, not known immunocompromised, presented with features of myositis with septic arthritis and cramps and showing a gram-positive foci. So how do we manage? So there are different options. Whether we give antibiotics plus debridement, we choose vancomycin, ticoplanin. Whether we choose ceftriaxone, cefazolin, or flucloxacillin for moving debridement. Just antibiotics without any debridement, or cefazolin alone for severe. So there can be different approaches.
दोनों same
But
हैं,
the key is
वो
that
पहला काम करके
we
बाद
have
दूसरा
to keep in
start
mind
करना।
whether there were, for choosing any empirical therapy, whether there were any risk factors for MRSA, whether
ये
patient
एक
had any
कैप्सूल
prior
है,
hospitalization, whether
10 दिन
patient
लेना
had
है।
exposure to
10 दिन कैसे लेना है?
surgical procedure
सुबह
in the
शाम
past,
5 दिन लेना है,
any use of
फिर रात को 5
intravascular
दिन
devices or intravascular access was there,
लेना है।
any transfusions. So in this patient, since there were no risk factors
बैठो
for
भैया, एक मिनट,
MRSA, we started the patient on
खुद
ceftriaxone
खड़े
plus indamycin. Patient underwent debridement.
उठा आंगल है।
Culture showed MRS.
No, sorry, after food.
So this is one of the very
ये इंजेक्शन लिखे हैं बस।
information that once particularly bacteria. So 2D echo should be done to rule out effective endocarditis. So in this patient 2D echo was done, which was showing a normal study.
फिर एक हफ्ता
The
10 दिन
patient
बाद
was
उसका
switched from
हीमोग्लोबिन चेक कर
ceftriaxone
लो
to ticoplanin based on culture
कितने हैं।
reports.
अगर एक 12 प्लस है तो प्रॉब्लम नहीं है।
So regarding
12 से less है तो
warriors, the choice of initial therapy depends upon whether it is CONS versus MSSA, MRSA, or H-visa. So for CONS, as Madam has already emphasized recently in the this review presentation previously, the duration is usually short for 7 to 14 days. For MSSA or MRSA, depending upon whether it is a complicated or uncomplicated bacteremia, the duration of therapy is 14 days in uncomplicated. And in metastatic infection, complicated infections without adequate source control, it should be around 4 to 6 weeks. Wherever there is a bloodstream infection of staphylococcus, metastatic complication should always be ruled out, and a patient should always be screened for IE. It sometimes happens that we when we do transthoracic echocardiogram at the beginning, sometimes it is reported as normal. But if we repeat echo after 4 to 5 days, that is usually recommended by IDSA that echo should be always done after 4 to 5 days of MRSA isolation. So it usually shows vegetation on transthoracic, or if not transthoracic, it will show a vegetation on transesophageal echocardiogram. If there is a localized focus, there is a potential antitoxin and toxin, and therefore clindamycin and linezolid addition should be considered in the antimicrobial therapy, and intense source control is required. So another case, 89 years male, diabetic hypertension, CAD, PTCA, presented with features of LRTI. CT chest shows lobar consolidation. Patient was started on meropenem and ticoplanin, and blood culture showed the growth of MRSA in 2 cultures. So what to do next? So like the scenario is that whether we continue ticoplanin, we switch to vancomycin, we add another agent, linezolid or clindamycin, we get an echo, continue same therapy as ongoing. So there was no evidence of vegetation. Echo was continued. After 5 days of therapy, patient had a worsening of sensorium. There was no change in TSC since the baseline. Repeat blood culture was negative. Then we again were stuck what to do next. So in this case, because there was a worsening of sensorium, the possibility of CNS involvement, metastatic CNS involvement was considered, and some other focus of metastatic complication. So PET scan and MRI was done, which showed evidence of liver abscess and meningitis. Linezolid was added. A repeat echo was done after 5 days of therapy at the time when patient was done, and it showed AML vegetation with severe AMR and AML perforation. Patient was referred to CTS for surgery. So this is a case of 67 years female CA lung on chemotherapy, presented with features of lower respiratory tract infection, consolidation with right side infusion. Patient was started on meropenem and ticoplanin. Purine fluid showed FIMA. There was no improvement in 2 days. So first culture 2 days later showed growth of methicillin sensitive staph aureus. So the patient was switched from meropenem ticoplanin to meropenem plus combination of daptomycin. but patient clinical condition deteriorates, chest infiltrates continue to worsen. So this example is important to understand that daptomycin has no role in treating pneumonia because of inefficient activity in lungs. And then also sometimes daptomycin has been known to cause eosinophilic pneumonitis, and therefore it can cause increase in the infiltrates and worsening. So regarding the discussion on other TPC, so this is a 33-year-old male CKD on MHT thrice a week, presented with fever with chills. Multiple cultures showed growth of Enterococcus faecalis, initially reported as penicillin sensitive. So how do we manage this patient? So Enterococcus is considered normally a commensal. It has low intrinsic virulence, but it is potentially capable of sepsis. Due to increased antibiotic use, there has been altered dynamics of colonization in gut, and that causes increase in DRE or Enterococcus infection. The problem with Enterococcus is that it is naturally tolerant to a number of antimicrobial compounds. Most common syndrome is UTI, but it can cause bloodstream infections, infective endocarditis, intra-abdominal infections, or CNS infections. Most common pathogenic species is E. faecalis, and the more resistant species is E. faecium. So no single agent is known to exert strong bactericidal activity against Enterococcus, and therefore the treatment is usually dependent upon combination of beta-lactam with the aminoglycoside synergy. So these are the algorithms for treatment of Enterococcus faecalis and faecium. So the principle is, so if it is penicillin and penicillin or aminoglycoside sensitive, it is treated with the combination of ampicillin or gentamicin. If aminoglycoside, it is treated with the combination of ampicillin plus ceftriaxone, or vancomycin plus, if there is intolerance to penicillin, that it is treated with vancomycin plus aminoglycoside. The treatment of Enterococcus faecium is more difficult because it is resistant to vancomycin often, and it is also resistant to multiple other drugs. So I think my next speaker will be covering the treatment of VRE in detail. So in this patient, we did an echo. There was severe MR and ER with TR, large vegetations on aortic and mitral valve. Patient was started on ampicillin and gentamicin. Later, high-level aminoglycoside was reported as resistant, and therefore there was no use of ampicillin gentamicin synergy. Patient was switched from ampicillin gentamicin combination to ampicillin ceftriaxone therapy for 6 weeks and CT-based review for surgery. So just a few words about one of the other less common pathogens. So this is 17 years old male, congenital heart disease, post-prostatic pulmonary valve in October 2022, presented with fever with chills without localization. So two sets showed the growth of gram-positive bacilli. So it can be diphtheroids, it can be bacillus species, it can be listeria. But when we did the gram staining, AFP staining, it was AFB positive. And I'm talking about mycobacterial infections. So these are the established cause of natural and nosocomial infections. These are usually not considered early. They are once there is poor response to other conventional therapies and to other conventional pathogens. It is the consideration of mycobacterial infections is usually late. The incidence has been rising due to growing population of immunocompromised and vulnerable individuals and complex medical and surgical procedures. Prevalence is variable from region to region, and global pattern is unknown. But the key message is that if there is a patient with appropriate mycobacterial infection, particularly that mycobacteria should be considered as one of the possibilities early. So just to summarize at the end, gram-positive infections, the burden is high, and the problem of AMR, of resistant gram-positive infections, has been rising. So we have to balance the high suspicion of index regarding empirical therapy versus overuse of antimicrobials and not predisposing to further antimicrobial resistance. So the key is consideration of bug drug site. So we think about the syndrome first, and then we think about what organism can cause it, what is the susceptibility pattern of that organism, and then we start the empirical therapy guided by patient's clinical presentation, post factors and risk factors for MDR. Not all GPC are same. That like Staphylococcus is not same as Enterococcus. The treatment considerations for Staphylococcus aureus is different, for cons is different, for enterococcus is different, for streptococcus is different, and therefore these should be considered differently. In a patient with staphylococcal bacteremia, endocarditis should always be ruled out. Metastatic assessed. MRSH coverage should be selective and not reflexive. That is, all patients presenting with pneumonia, all patients presenting with a skin and soft tissue infection need not be started on empirical MRSA antimicrobial therapy. It should be targeted based on patient-specific risk factors, severity, and local epidemiology. Source control should be done wherever possible, like including drainage of abscesses, debridement or removal of infected implants or devices. There is definite availability of newer antimicrobials. The scope is huge, but again, because if we are not going to use them judiciously, we are going to lose them very soon. So I would prefer if everyone thinks in terms of using these newer antimicrobials as a targeted agent rather than empirical. So when we have a culture report, we can use them for targeted modification. And the last, a very important point regarding these multi-drug resistant gram-positive infections is regarding IPC. So contact precautions, if we are following very diligently, we can break the chain and we can prevent the transmission of such multi-drug resistant gram-positive infections. So this was all from my side. Thank you, sir. Thank you, listeners. So if there are any questions, I think we'll be taking at the
Stop sharing.
Sure, sir. Sure. I will share.
So thank you, Dr. Rohit, for that very nice presentation, very comprehensive, and taking questions later. So with that, we move on to our next presentation, which is by Dr. Sayan Maharatna, who is currently Assistant Professor of Infectious Diseases in Medicine, Kolkata. He has done his infectious disease from AIIMS, New Delhi, where he was involved in undergraduate and postgraduate medical education and training. He has expertise in critical care infections, antimicrobial stewardship, infection prevention and control. He has various research interests, publications and presentations in many national and international conferences. And he's also in international journals. So may I now request Dr. Sayan to begin his presentation on MRSA and infections.
Thank you, ma'am, for the introduction. So, am I audible and slides are visible?
Yes, yes.
Okay.
Your slides are not seen.
Share.
Not shared. Please share your slides.
Are these visible?
Yeah, just go to the screen, the slideshow mode. Yeah, that's fine.
Okay, so my previous speaker was my senior, Dr. Rohit. Almost has covered a lot of things on MRSA and BRE, so we will have a bit of overlap. So I will keep my talk. So I'll keep my talk with the following outlines: understanding the MRSA and BRE, understanding the bugs, their biology, their epidemiology, and the problem statement regarding the MRSA and BRE in our setting and in the global scenario. Their resistance mechanism and the most important laboratory interpretation of the cultures. When to cover, whether it's a colonization versus infection dilemma, and various syndrome-based treatment decisions making by some case scenarios I will discuss, and some therapeutic challenges and salvage strategies regarding extensively or multi-drug resistant organisms like MRSA and BRE. And at the end, I will discuss about the prevention strategies for both the bugs. So this has already been discussed. So for MRSA, for the Staphylococcus aureus, the evolving drug-resistant picture, as we all know, has been very like for a long time in the mid 70s, 80s, vancomycin was used, but since 1990s, vancomycin resistance was isolated. So regarding the mechanism of resistance, as my previous speaker already has discussed, the acquiring gene causes the change in the penicillin binding protein, and which leads to resistance to all the beta-lactam, because it doesn't let the beta-lactam ring to bind the penicillin binding protein and disrupt the cell bacterial cell membrane. So what is the problem statement in Indian scenario? So it's a systematic review and meta-analysis of 34 Indian studies with 16,000 patients. So they the pooled MRSA proportion from the studies is 27%, and this shows us a high burden among the ICU patients. And this is the AMR surveillance network data of 2024 ICMR, where we can see from various samples what is the prevalence of MRSA and MSSA among all the Staphylococcus aureus isolated. So from the superficial infection, deep infections, and even from the CSF shunt infections, MRSAs are more frequently getting isolated. So, what are the epidemiological phenotypes of MRSA? So, it can be hospital acquired, community acquired, healthcare associated. So, these terms and these terminologies are important because in case of hospital acquired, the MRSA can be having more tendency to have multiple drug resistance to even to other agents like vancomycin or higher MICs, because they are hospital acquired and more seasoned to higher antibiotics. Community acquired MRSA patients may be younger patients coming from the community without any hospital exposure. Healthcare associated within the window period of 48 hours of admission, but having previous history of hospital admission due to hemodialysis or surgery. And another thing is inducible dormant MSSA kind of picture. This is of microbiological importance, not that much clinically relevant, but some MRSA can behave like an MSSA, and once we give antibiotic, we get to know that they are basically behaving like an MSSA. So coming to our first case, that is a middle-aged female patient, basically had a dental extraction and was asymptomatic, but for the 2 weeks before admission, she developed fever, and since the last 3 days, she had an rapid onset heart failure. So by multiple cultures, MRSA was isolated, and from the echocardiography, there was severe aortic regurgitation and alveolar vegetation. So this was a kind of this is a kind of typical picture we tend to get in MRSA. So what kind of management protocol, what kind of treatment protocol we are going to advise? So first of all, because of the guideline-based therapy, initial therapy was vancomycin monotherapy, but after 3-5 days of antibiotic vancomycin, MRSA was persistently getting isolated. So in that case, there was kind of treatment failure, and they may have had MIC towards vancomycin, but what are the options next? One option is always there is a large vegetation, so surgically correct the valve and remove the infection. Other is we'll have to shift to other antibiotics. So we need to know what are the other strategies that are available. Daptomycin, and we need to know the theory behind combining another agent of beta-lactam with daptomycin in this kind of scenario where there is a possible synergy between the antibiotics. So basically there is a seesaw effect we will discuss later. So that was utilized, and daptomycin cephalosporin was the treatment of choice, but vancomycin was ineffective. Then summarizing the anti-MRSA agent, this slide doesn't need some I will discuss everything in the following slides. So first of all, as it was discussed by the earlier speaker as well, that where do we give vancomycin and where do we give teicoplanin? So microbiological cure rates, mortality rates, both the drugs give the similar rates. Teicoplanin is as good as vancomycin for MRSA pneumonia, that has been shown in various observational studies. But another important thing from teicoplanin point of view is less nephrotoxicity with teicoplanin. So what is being recommended is the dose of teicoplanin we need to understand. Routine skin and soft tissue infection, the dose is 6 mg per kg, BD dose. And in case of teicoplanin, the trough concentration will be important. And severe infections in the form of sepsis and having systemic complications will use a higher dose. And when we do load for 5 doses, we tend to load for 5 doses when there is a high inoculum and difficult source control. So kind of osteomyelitis, endocarditis. In those cases, loading is the most important thing with ticoplanin. So we need to keep that in mind. In case of, if we compare vancomycin versus linezolid against the gram-positive infections, linezolid advantages are it has a very good pulmonary penetration, very higher than the plasma level in the lung, but oral viability is also very good. Not needed IV all the time, 100% oral viability. And the vancomycin disadvantages of vancomycin shows MIC creep. Over the time, vancomycin's MICs are increasing and has poor penetration to the lung and also nephrotoxicity. So all these things will make linezolid a better choice for if sensitive for the pulmonary involvements. In case of daptomycin, most of the MRSs dies within after giving the daptomycin, it is approved for a lot of infections, but complicated skin and soft tissue infections, MRSA endocarditis, and also for bacteremia. But it has no role against the gram-negative organisms. And another important feature is no role in pneumonia. CPK monitoring is needed. So we need to know the doses. The doses, it depends on the daptomycin MICs as well, but left-sided infective endocarditis, persistent bacteremia, prosthetic valve involvement, they need higher doses. Why left-sided one need higher doses? Because the right-sided one, the study which gave the right-sided one 6 milligram per kg, they showed benefit, and left-sided one are also associated with further complications of embolizations as well. So that's why we tend to give a higher dose in left-sided infective endocarditis for daptomycin. Tigecycline is mainly for complicated skin and soft tissue infections. I will discuss about what are the complicated skin and soft tissue infections. And also another important point is intra-abdominal infections. It is non-inferior to vancomycin in case of skin and soft tissue infection, but it is not a first line in case of ventilator-associated pneumonia. And also tigecycline excretion is very poor via the urine, and so not recommended for UTI. So what are the clinical syndromes and critical management concerns regarding the MRSA? Bloodstream infections, infective endocarditis, TAP, HAP, and skin and soft tissue, bone, joint, and CNS. So I will come to one after the other. So MRSA VAP infection in India, the gram-negative organisms are the majority, but less than 20% may be due to MRSA. Linezolid is non-inferior to vancomycin, as I told. Another important thing is we tend to use a lot of procalcitonin in the beginning of the VAP, but in a gram-positive organism like MRSA can also lead to involvement of cytokines, which can lead increase in PCT in the beginning. So that has not much role in differentiating MRSA versus gram-negative in the very beginning. So when to add empirical MRSA coverage in a VAP patient? So this we need to know in an ICU where we need a empirical coverage for MRSA. Emergence, whether the intubation was emergency or tracheostomized patient, that tells us about the chronicity of the ventilation. Also, in cases of reintubations and elderly men, higher Apache scores, immunosuppressions, prolonged antibiotics, and prior hospitalization history. So these are the factors which which makes us more towards covering MRSA in VAP. Coming to another case scenario, this is a 65-year-old male smoker with COPD and now admitted to ICU, has multiple admissions, multiple antibiotic history, past admission due to COPDs, and now develops VAP. So till now we don't have cultures. So should we cover the MRSA in this case? And if yes, then what basis? So I discussed just now whether we need to cover the MRSA. So in this case, we need to cover in a VAP of this kind of a patient, we need to cover with linezolid or any MRSA coverage for the patient. Coming to the CAP, so community acquired pneumonia, among the community acquired pneumonia, MRSA is an infrequent cause. For all the staph aureus community acquired pneumonias, MRSA among all the staph aureus, 30 to 60%. So all the patients with the CAP should be evaluated for the risk factor of infections with MDR pathogens. So for this evaluation, we'll have to check the history of chronic respiratory diseases, local antibiogram, family member having MDR, or hospitalization history of the patient, and underlying immunosuppression. And another pointer which was discussed earlier also, cavitation, necrotizing pneumonia, empyema, massive hemoptysis, and there are underlying immunosuppression in the form of neutropenia, skin changes, rashes, and concomitant SSTI, concomitant skin and soft tissue infection. They can give us a clue towards possible MRSA community-acquired pneumonia. So, empirical community-acquired pneumonia coverage. Mostly, this list will be shorter, but IV drug abusers, patients who are known nasal colonizers, post-influenza community-acquired pneumonia setting, close contact with MRSA carriers, and some environmental like army or people in prisons, they can have trauma and also local skin infections, and they can have that kind of community-acquired pneumonia. So another important issue is clinical symptoms of MRSA bacteremia. So when to consider a patient for empirical coverage of MRSA in a bacteremia is, so similarly, recent dialysis, IV drug abuse history, apostolic valve, recent hospitalization, they come into play. And another important thing is the bacteremia complicated or not complicated? Complicated in the form of implanted prosthesis or endocarditis, and follow-up cultures are also coming positive after initiation of therapy, and the patient is not improving clinically. So evidence of metastasis needs to be checked here. So what drug to give? Vancomycin, when we give for MRSA bacteremia, now we tend to give, we don't tend to follow the trough levels. We tend to follow the AUC guided dosing. That is the AUC 24-hour AUC by MIC ratio, that is 400 to 600 is recommended. More than 600 may cause toxicities, less than 400 is suboptimum. So complicated bacteremia, vancomycin will be better than teicoplanin in cases of, and daptomycin is used rampantly in US in place of teicoplanin, but cannot be used if the bacteremia origin is pneumonia. Teicoplanin in severe infections, 12 hourly 3 doses, but in cases where the load, like the source is not getting controlled in endocarditis, we will have to give 5 doses for loading. Loading is very important in teicoplanin, as I told before. So for vancomycin, this is more indicated to measure the AUC MIC ratio that can be done with the available softwares in the internet, and critically ill patients, concomitant nephrotoxic drugs, having renal injuries, and obese patients, they become much more important even in the burn patients. Another important thing is synergy with beta-lactam in cases of MRSA bacteremia with vancomycin or daptomycin. So synergy was shown to be important factor in cases of this MRSA and VRE infection treatment when there is a seesaw effect. I will discuss later. But in this case of MRSA bacteria treatment, synergy showed that there are much more. There is no improvement in terms of mortality benefit or outcome benefit. So otherwise there was more chances of acute kidney injuries in the combination arm. So these kind of synergies are only salvage strategies where beta-lactam and vancomycin is given together in case of MRSA rather than upfront treatment. These are basically used when the usual treatment is not working or MICs are higher, otherwise not. That is the message from this camera to trial. Another case scenario I am discussing here, that is male patient. Here the skin and soft tissue infection and complications I will discuss. So 7 days history of fever was there, and there was a skin lesion after azithromycin for the fever, and cefotaxime was also given. So the patient received 2 courses of antibiotic for a fever and developed this kind of skin lesion. So acute generalized exanthematous pustulosis. So that was the initial diagnosis of AGIP, and because of that he was admitted, and that for the fever evaluation and this complication. So also viral markers were negative, but the pus and blood, both cultures showed MRSA. So it was a community-acquired skin and soft tissue kind of infection. He gave superaddedly infected with MRSA, and there was neutrophilic leukocytosis, and CRP was high. Along with that, the patient also developed tachypnea, and we saw that there are some right middle zone opacification, and we'll have to. So there are systemic complaints by now. Azithromycin was given, cefodoxime was given. Patient developed agape, and then the rash appearance happened, and the patient stopped antibiotic. Now the patient is in frank sepsis. So, with the confirmation of MRSA, the patient was started on vancomycin, but vancomycin flush syndrome or Redman syndrome developed. So, we had to change the antibiotic from vancomycin to ticoplanin. So, ticoplanin we had to load according to the body weight, and that gave relief to the patient, and the situation improved. So after that, what we did, adjunctive management also was important. Topical mupirocin was also applied to the open lesions, and chlorhexidine bath was given to the patient, and final resolution of MRSA bacteremia pneumonia was there. So this was a skin soft tissue infection, community acquired MRSA, but which took a bad turn, and who needed IV antibiotics for that. So, so this is a classical example of a complicated SSTI. Other complicated SSTIs are where the pus is deep inside the tissue, need for surgical intervention, impaired host defenses, host is immunocompromised, systemic illness is there, and infection associated with devices. So MRSA pointers will be like much more virulent, and systemic signs, infection history, colonization history, IV drug use history, that should be there, but that can be there, but systemic signs will be more predominant in MRSA. So, as my previous speaker also has summarized these things, but newer anti-MRSA agents are coming, and ceftaroline, tazobactam, dalbavancin, nivolumab, so all these are basically the classic ICU backbone is vancomycin, daptomycin. These are the classic backbone for ICU MRSA management. These are basically approved for acute bacterial skin and skin structure infections, and ceftaroline has very good lung penetration, so community acquired pneumonia also. And ceftaroline has also role in salvage therapy as a combination with daptomycin or raptomycin for bloodstream infections. And these are basically useful in completion of therapy for OPAT and all that. UTI. If we get a Staph aureus MRSA in UTI, in urinary samples, we'll have to exclude the MRSA bacteremia first, because that is the most common route. Otherwise, if cystitis is the only picture, then doxycycline ceftriaxone can be given. Otherwise, complicated UTIs will have to take help of vancomycin and or ticoplanin. So, bloodstream infection where there can be a possibility. Otherwise, catheter associated, replace the catheter, but doses of vancomycin, ticoplanin. Otherwise, replacing the catheter would do most of the job. Linezolid is not that much recommended because of poor renal excretion. Other infections like bone joint CNS infections, in osteomyelitis, prosthetic joint infection, we need to know that multiple joint fractures, multiple sites of infections, more systemic features, they will more tend to point towards MRSA, because we most of the time don't get the MRSA, most get culture positive from these kind of infections. So they will need, based on whether the early infections, late infections, they will be requiring antibiotics based on that, and the duration and all that, and repeat imaging and CRP monitoring. Surgical debridement plays an important role. In CNS infection with MRSA due to some CNS surgery, post-surgical, vancomycin is the first choice. Alternative choice is linezolid. Sometimes rifampicin, in the last IDSA guidelines, they were adding rifampicin, but that was not the rule all the time. Most importantly, prevention. So, regarding the prevention and screening for MRSA, several trials, reduce MRSA, abate infection trials, they showed that for all the patients of the ward, general patient, you don't need to blanketly give chlorhexidine bathing to everyone. But that is not beneficial. So, the latest recommendations is adult ICU patient, universal decolonization might help, Surgical patients, screen the patients undergoing this kind of surgery and decolonize. Non-ICU patient, no need of blanket decolonization for everyone. So prior antibiotic use, prolonged hospitalization, surgery, admissions, living in long-term care facilities, nursing homes, these can be risk factors for screening MRSA. How to screen? Single site screening is not that much good. Both side nasal and perineum screening is better. How to decolonize? Mupirocin for 5 days, ointment locally apply, and chlorhexidine bath for 5 days. So practical steps that goes in line with the international guidelines as well. With the central line, peak line, they can be considered daily bathing with the chlorhexidine. So coming to next organism, that is the vancomycin resistant enterococcus. Enterococcus are difficult bugs. Coming to first case scenario. So a SLE patient on immunosuppression presented with 2 weeks of abdominal pain. Initially thought lupus nephritis, but she also had temperature. Imaging was suggestive of lupus nephritis and started on MPS pulse. But the patient worsened after pulse. Septic shock happened, and this was a blood picture with neutrophilic leukocytosis, and broad spectrum antibiotic meropenem vancomycin was started. So chest X-ray showed lobar consolidation, and mini-valve was collected, sent for workup, and from the blood culture revealed 2 organisms: Enterococcus faecium resistant to vancomycin, daptomycin, leucoplanin, and even linezolid. And Klebsiella pneumoniae was isolated. So in this kind of situation, how to proceed? So we'll discuss the bug a bit. So what should be the microbiological approach for an intensivist? So the bug is a contaminant, Enterococcus is a contaminant. Which Enterococcus is it? Is a very values of faecium, resistance pattern, intrinsic resistance, and the drug of choice. So basically what we shown here is basically the microbiological tests, the colony characteristics. So coming to the basically the organism, gram-positive organism, which is facultatively anaerobic bacteria. These are considered tough bugs because they can long survive in the environmental surfaces. Commensals of the GIT, that is very much important to where they are basically commensals, frequently in the vagina, and they are tolerant to heat, they are tolerant to chlorine, and most are non-motile, but Gallinarium catholic they are motile, and they give the golden color colonies as well. Species, all the species, most important is Fecalis and Faecium for human infection. So towards becoming multi-drug resistance, there are various mechanisms. In last speaker has also has discussed. So what is the point is the point is they have multiple ways of developing resistance. Even for aminoglycosides, aminoglycoside modifying enzymes gives a high level resistance, and for vancomycin they have a VAN-A gene which alters the lactate DLA position of the pentapeptide chain where the vancomycin typically binds. Other when monotherapies were introduced for these bugs, they gradually developed resistance to all of them, even for linezolid and daptomycin, like the bug that was isolated in our case. So coming to the global prevalence, Fecalis and Faecium, we can see that Faecium is much more prevalent, more than 40% prevalence of Faecium in some of the countries. But in Indian scenario, the prevalence of the vancomycin resistant Fecalis and Faecium are basically lying between 5 to 10%. So among the total isolates, Enterococcus, 89% were Fecalis and Faecium. So most of them are causing human infections were these 2 in our Indian ICUs from the ICMR AMR surveillance network data. And the Faecium from 2017, it has increased to 3%, and an observed increase was there in Fecalis isolate was also there. So susceptibility of Enterococcus, if we focus on Faecium, we will see that vancomycin and linezolid, both sensitivities, susceptibilities are a bit decreasing. They are those 80% susceptible, but they are now going to decrease in the coming years. So another meta-analysis, last 2 decades they've tried to get the prevalence. So in the 2000-2010 prevalence was 4.8%, and in the next decade the prevalence rise to 14.1%. So there is a progressive emergence, and there are a regional variation, heterogeneity across the Indian states are there, but higher in the tertiary care hospitals. So Enterococcus faecalis and Faecium were the most predominant in the epidemiological data. So what is the impact of these VRE infections? So mortality impact is there. So a VRE bacteremia has a higher mortality than the vancomycin sensitive one, and length of stay is also higher in VRE bacteria. What is the patch?
Dr. Sayan, please can you try and wind up in the next 5 to 10 minutes?
Okay, ma'am. So basically, if we give ceftriaxone to this organism, prolonged antibiotic exposure can selectively give more enterococcus in the gut, and they can get into the bloodstream and cause the bacteremia. And also some patient host related risk factors like immunosuppressed conditions and other patients in ICU having central line or catheters, they are also having this pathogen in the system. Routes of transmission in the hospital from the surfaces, contaminated doors, handles, and from contaminated healthcare hands of healthcare worker and contaminated equipment, they can transfer from person to person. Most important thing is interpretation of resistance. So these bugs are intrinsically resistant to Gallinarum cassilicella was intrinsically resistant to vancomycin, but Faecium faecalis, they have intrinsic resistance to aminoglycoside, clindamycin, trimethoprim, sulfamethoxazole, like cotrimoxazole, they have this intrinsically resistant. So this we need to know whether even if they show sensitivity in the in vitro studies. So in case of MICs, if enterococci shows MICs less than 16, then it is susceptible, but above 16 but less than 64, they can be given high dose ampicillin provided there is a high level aminoglycoside resistance is negative or absent. So what is this high level aminoglycoside resistance? This is important where the disc with very high level concentrations of streptomycin or gentamicins are respectively used, and they figure out whether the strain is high level aminoglycoside resistant or not. So in our case, when the patient had linezolid resistant and daptomycin resistant, so daptomycin monotherapy was given, but in this case, strongylolytic hyperinfection was also there, so which caused the bacteria to grow, come into the bloodstream. So daptomycin with ceftaroline or this combination could have helped this patient. The patient succumbed. So coming to all the clinical syndromes with scenarios, this is the bloodstream infection scenario where the enterococcus is sensitive to linezolid only. So in case of bacteremia, whether monotherapy is enough, whether what should be the first antibiotic of choice, and whether echocardiography is needed. These are the most important things. So echocardiography, I will talk about echocardiography. There is a scoring, a de novo scoring. In case of Enterococcus faecalis bacteremia, this scoring gives the sensitivity of 100% of the need for transesophageal echocardiography if more than 3. This scores incorporates duration of symptoms, embolization, origin of infection, valve disease, and murmur positivity. So coming to the approach to the faecalis bacteremia, first step is whether the faecalis is ampicillin susceptible. If the ampicillin is not susceptible, then whether it's the vancomycin resistance. If it is a vancomycin resistance is there in the faecalis, then dapto and linezolid will be the options. If the bug is ampicillin susceptible, we'll have to see whether the bacteremia is uncomplicated or complicated. If it is uncomplicated, ampicillin alone will work. If it is complicated, then we'll have to check high level aminoglycoside resistance. If high level aminoglycoside resistance is positive, then we can't use aminoglycoside. Ampicillin ceftriaxone can be an option. But high level aminoglycoside negative, resistance is negative, then ampicillin or ceftriaxone ampicillin with gentamicin can be given. So this synergy basically is using up all the PBPs together, and this causes a synergy between ceftriaxone and ampicillin. So coming to the Faecium bacteremia, first step is ampicillin susceptible or not. If it is ampicillin susceptible, which is rare, less than 5% cases will be ampicillin susceptible, uncomplicated will be dealt with ampicillin alone. In case of complicated one, or ampicillin resistant. If VRE, then we will give daptomycin, check the daptomycin MIC. Daptomycin MIC, if less than 4, then we can give a daptomycin with a beta-lactam combination. If daptomycin MIC is higher, then we'll have to sort to linezolid. This is a very simplified approach to the bacteremia. So this is the seesaw effect where daptomycin with beta-lactam gives the synergy. So in case of daptomycin persistently positive blood culture, we can use this seesaw effect where beta-lactam can be added. Endocarditis or a higher MICs combination is favored, where ampicillin alters the charge and helps binding daptomycin to the membrane. So this is basically e-fecalis you are getting from Foley's in an ICU patient, post-surgical ICU patient. So where do you tend to find it important? Whether true infection or colonization, you'll have to see. So in case of a, if you find enterococcus from urine, you'll have to see whether asymptomatic bacteremia will only treat in pregnant patients or urologic procedures. In case of cystitis or uncomplicated ones, amoxicillin, nitrofurantoin, fosfomycin. So amoxicillin is very high urinary concentration. So this can be helpful. And if resistant UTI or complicated UTI, then IV ampicillin if ampicillin susceptible, or ampicillin resistant, then linezolid, high-dose daptomycin are the options. So I told that aminopenicillin has a very good concentration in the urine. Even if resistant, for cystitis, aminopenicillin ampicillin can be used. So in case of pyelonephritis, we can see that the daptomycin, fosfomycin, linezolid, they have a fraction unchanged in the urine, kind of above 50% for daptomycin, fosfomycin. But in case of renal shutdown, chronic glomerulonephritis, the concentration falls 50% of the serum levels. So that we need to keep in mind. Always, if this were a patient who developed this enterococcus faecalis for the first time in the first stage of infection, then it would be important. But otherwise, multiple drainage, enterococcus can be a colonizer here. So you'll have to check whether the patient host factors severely immunocompromised or not, whether the blood culture is positive or not, in that whether the patient is not responding to the Klebsiella pneumoniae treatment or not. In those cases, we'll think about enterococcus faecalis treatment in such a patient. Another is a infant who post pyogenic meningitis having developed hydrocephalus, vancomycin resistant enterococcus are coming, VANA positive. So device associated vancomycin enterococcus like VRE ventriculitis we are dealing with here. So in case of meningitis, if we'll have to establish that the susceptibility pattern, and if ampicillin and vancomycin susceptibility we have, then if vancomycin susceptibility, vancomycin can be used. Otherwise, ampicillin susceptible, high dose ampicillin is a very good option for CNS. Even gentamicin can be added with high dose if a high level amino acid resistance is negative. If it is a VRE, vancomycin resistance, then daptomycin will have poor penetration, so linezolid will be an important for dealing with meningitis. So this is where the colonizer or whether it's an infection. So this kind of superficial wound swab, respiratory culture is very much important. Most of the times colonizer, biliary stent or drains cultures, most of the time they are colonizer. So for prevention, to be very rapid, how to screen for the vancomycin resistant enterococcus. So only for high risk patient, ICU transplant units. It's not recommended for all the patients. And these are some techniques of screening. I'm not going into details now. Whom to screen? Only for high risk immunosuppressed transplant hematological malignancy patients. Carriers, strict contact precautions, strict hand hygiene for the carriers, and decolonization and screen is not recommended for healthcare workers or not recommended for all the patients. Unlike the MRSA and VRE carriers management, we can tag the patient as VRE positive and will not rescreen in the same admission, will rescreen on the readmission. And since the last culture positive or since the last negative rectal cultures 1 month apart, we will be removing the tag. So accordingly, so the most take home message is we should treat the infection, not the culture. So most of the cases, MIC matters, PKPD matters. In cases of successful treatment, site decides the drug and decides the doses. And older drugs are in combinations, are useful. Persistent infection, will have to search the sources, and also prevention. Prevention is most of the time better than cure because it's a very difficult. Thank you so much. Any questions we can take?
Yes. Thank you. It was a very, very good presentation. Yeah. So, so I think with that, shall we, Dr. Chawla, shall we take up the questions in the chat box?
Yeah, please start asking them.
Okay.
Stop the sharing.
So the first question is that how do you differentiate? Okay, so there are just a couple of points that I also wanted to make, before we go on to the questions. The first is that, this thing about Vanco and Tico, one of the things is that, if you have a patient in septic shock, I mean, maybe vancomycin might be a better drug to give because Tico is highly protein bound. So, and you must remember that the loading dose of vancomycin is 30 mg per kg, and therefore you can give up to a dose of 2 grams. That is one point which I wanted to make. The second point is that ecoplanin should probably not be used for endocarditis. Okay, so it's not preferred. So, TICO not for endocarditis and not for CNS infections. That was one point which I wanted to make. But yes, that is very important that, because you have so many MRSA drugs, you really need to choose properly from that array because not every drug is interchangeable. So that point was really well brought out by both the speakers. And another point which I wanted to make is that in chronic therapy, linezolid has a lot of problems in terms of not just the side effects, but also the tolerance, because many people just don't tolerate linezolid. They have a lot of gastritis and anorexia, and that is where we are finding tedizolid as useful because tolerance is better and side effects are less, and also the bone marrow suppression is less, but we don't know whether the efficacy is the same. So those are just two points which I wanted to make. So with that, the first question, maybe I can ask this to Dr. Rohit. How do you differentiate Staph aureus from pneumococcus at the bedside? And at what point does the clinical and radiological pattern drive your empiric antibiotic choice?
So I think it is very important if we have a patient with pneumonia, particularly coming from community settings, to differentiate whether it is streptococcus only or whether there is a possibility of staphylococcus. So there may be certain few clinical indicators such as like streptococcus pneumonia is basically a community-acquired pneumonia, but in case of Staph aureus, it can be a hospital-acquired pathogen. So if you have a setting in a hospital-acquired setting, patient developing post-influenza pneumonia, so then MRSA should be a consideration in the other patient. Certain other factors like presence of cavitation in chest imaging. So because most of the community-acquired pneumonia, post-influenza pneumonia are usually caused by community-acquired MRSA isolates, and they have a tendency to produce PVL toxin. So PVL toxin is known to cause necrotizing skin and soft tissue or soft tissue infections. So it is so if there is a community-acquired MRSA infection, so we can find some necrotizing cavitatory lesions in patients who will be suffering from a community-acquired MRSA infection, which is less frequent, less common in patients with streptococcus pneumonia. Empyema may be seen in
Empyema may be seen in both, but I just wanted to ask you that sometimes you can have a very fulminant pneumococcal infection also.
Right.
You can have pneumococcus which can cavitate and which can cause empyema.
Yes.
And in that case, I think your urine pneumococcal antigen test, which you can get back,
definitely,
and your blood cultures may be useful because it may
definitely.
But yes, pneumococcus can also be quite fulminant.
Invasive. Yes.
Invasive, and
so if there is a doubt, like there are just findings which are favoring the possibility of MRSA, then in those conditions, MRSA coverage empirically should be considered at the onset.
So, Dr. Sayan, I would like to ask you that are you actually doing this AUC by MIC in your patients on vancomycin? Like, are you doing the trough and the peak levels and then putting them on the online calculator to generate a AUC by MIC in clinical practice?
That is very much difficult because the levels we need at least we need the data of several data to put in the calculators. The dose what dose, what duration of therapy, and the trough levels at the peak we need to calculate after giving the dose. So all these data are required. So that is very much difficult in this setting.
So I mean that is a difficult thing to do. In fact, there was I think an editorial also on that, whole supplement or that whole article which came out on this AUC MIC based dosing. That is it just too much of an exercise. So are you still then doing trough levels to guide therapy, like you do aiming for a trough level of 15 to 20 to guide therapy, or have you actually moved away from vancomycin in treating MRSA infections?
In our setting, ma'am, vancomycin limiting factors mostly development of AKI, development of and persistence of bacteremia, non-responding patients. So then we tend to shift to other drugs. Otherwise, it's very difficult in low resource setting to shift based on trough levels either. I mean,
so you don't do basically any kind of levels in your practice. You start with vancomycin, and then if there are problems, then you shift to another drug.
Yes, in the low resource setting, this is the practice. This will be the practice in most of the setting in India.
You're not doing any levels, like neither trough, neither are you using AUC by MIC. So
the other problem is it is expensive to get it done. The turnaround time is less.
Yes.
And like for AUC,
turnaround time is actually more.
12 hours, 24 hours, and then you have to put in the algorithm, and then they find out. But I think we can follow what the West is doing at many centers. So we can follow what is the dose appropriate in certain conditions. I think that's most of the time. But trough level, many of the tertiary centers are doing.
Yeah. So
I mean, they're doing levels, but it is expensive, so you get trough level. Although now it is recommended not to use trough levels for giving vancomycin.
No, the reason they have said that don't use trough levels is because in the trough, by following the trough levels, you are maybe increasing nephrotoxicity. So that is the reason why they say that you don't use trough levels. But sometimes, at least that is some, that is something which you can do. So we are doing trough levels. But the problem is that if the turnaround time is more than by the time you get the level report, the patient's creatinine has changed, and therefore it is not applicable. So those are the problems with vancomycin trough level estimation. However, if you have a stable patient with then maybe and you are treating endocarditis, that is the kind of patient
Not
where I
drinking water
think
also.
you should attempt
Water I
to
drink.
do
Water.
AUC by MIC.
Water I drink.
Because there you will be giving that patient vancomycin.
But I was drinking cold water.
For example, MRSA endocarditis. There you could make that effort to do that calculation.
Not from French.
So I think I'll just a second. One of the most important thing is that the teicoplanin is now like everybody's using teicoplanin, and as Dr. Science said, it's not a good drug for endocarditis, because even in endocarditis you come across people who are using teicoplanin.
So that is the important point which I said that these
Kara masala खाएगा नहीं सादा खाना
CNS infections, because these are three things where you should not be substituting vancomycin with teicoplanin.
But 15. Teicoplanin for septic shock, for other reasons people are using. And because they feel safe because of nephrotoxicity and non-availability of the unpredictability of vancomycin.
Yes.
Yeah, so I think the reason why they get away with it is because most of the times the shock is not because of MRSA. Yeah.
Yeah,
that is the reason.
That is another reason, because we don't have MRSA most of the Indian ICUs. It is basically gram-negative, the Klebsiella, Pseudomonas or Acidobacter. Almost 80%.
Water also you
So that is maybe another reason, but we prefer, whenever there's a lung problem, I prefer Linzolid more than anything else.
And another problem is that we did an audit in our hospital and we found the most misused drug is teicoplanin, because you don't have so much of a MRSA problem either in the community or in the hospital, and most of except for the syndromes which they have described, and yet every patient who comes gets started on meropenem and teicoplanin. whether he has sepsis acquired in the hospital or outside the hospital, without considering. So I think there is a tremendous need for antimicrobial stewardship as far as the gram-positive drugs are concerned. Because there is a lot of misuse of these drugs, especially teicoplanin. So I think we are running out of time. So I would like to state one important point about, this thing of, what to do, like when your patient with an MRSA infection, let's say an MRSA pneumonia, with who is on vancomycin is not improving, or let's say who's on teicoplanin who is not improving, because there are issues with lung penetration of both the glycopeptides, whether it is vanco or tico. So you, as Dr. Chawla said, I think we should be switching to other drugs for treatment of MRSA pneumonia. And you have excellent drugs like ceftaroline, you have levonadifloxacin, which has excellent PKPD for the lung, or linezolid. So that's what, I mean, do you have any difference of opinion here? Because there are several questions related to MRSA pneumonia and what to do if they are not improving on vancomycin. So I don't think we should be using vancomycin to treat MRSA pneumonia.
Yes, definitely, ma'am. Like I do agree. If we have a patient who is suspected MRSA pneumonia and patient doesn't seem to be in septic shock and there are no multiple like other organ dysfunction, and we are not suspecting bacteremia, just pure MRSA pneumonia is the clinical presentation. So then in that patient, even isolated use of linezolid should be considered at the beginning, or even if patient is not improving on vancomycin, even like let's say after 48 to 72 hours.
Yeah, and apart from that, you have, levonadiflox, which is a very good drug, with the added advantages that when you start your empiric therapy, in such a patient where you're thinking of MRSA, you also want to cover your atypical organism. Then levonadiflox will cover your atypical, it will cover your MRSA, and then you add a beta lactam to that. So, I mean, that would be an advantage, because when you're facing a pneumonia coming from the community, you may even want to cover atypicals at that point. You will not know whether this is a pneumococcus, whether this is MRSA, whether this is Legionella, whether this is mycoplasma. So then if you use drugs like linezolid, then you will be using beta-lactam, you will be using a linezolid, and you will be using, let's say, clarithromycin or erythromycin or doxycycline. So I think there is a scope for using that drug in patients with suspected community-acquired, MRSA pneumonia. And once you have the pathogen, then you can probably change treatment.
I do agree, ma'am. Like, I've never personally used levonadifloxacin, but I have slightly one additional perspective because it's a newer drug. It has both IV and oral availability. Patient can be switched on from IV to oral after like initial improvement as a outpatient therapy for just continuation of therapy for completion of therapy. And it is a very good bactericidal agent. So use of levonadifloxacin or for that matter any other newer antibiotic.
Yeah, it's been misused.
Yeah. So I think if it is just because most of the labs are not reporting levonadifloxacin susceptibility. So if we have the susceptibility, it may be or it should be preserved for targeted use after positive cultures. I think that should be that is my take.
The other thing is what I feel. I've been practicing clinical care for the last 25 years. Like patient is not responding if you started gram negative. Probably it is taking time. You add up another drug like gram positive and you think the patient has responded. If you really ask Dr. Rohit, how many proven gram positive you started living, you must have started almost 90% empirically and thought that patient is responding. This is a problem because the patient right at the periphery gets a meropenem and teicoplanin. When he comes to the hospital, you don't grow anything and you really don't know what you are dealing with. And then eventually he stays for some time and then you keep on giving polytherapy. I think there is a lot of need for stewardship. What we do most of the time in even community-acquired pneumonia, patient come with meropenem, teicoplanin, we start ceftriaxone and maybe doxycycline. Patient response. So I think purpose of this course which we are going that you please go methodically so that we can reduce somewhat this MDR. Go ahead, please.
I think that's a very important point, and I think there is a lot of misuse of gram-positive drugs, whether it is Vanco, Tico, Linezolid is such an important anti-TB drug that I don't think we should be using it empirically in pneumonia because many times TB can present as community-acquired pneumonia. And if you start using linezolid empirically, and what if it is TB which you have missed? So that is a problem. So with that I think it's 9:30. So
we can have few more questions. No problem.
okay, we can take few more questions. So I think a very important point you brought up, Dr. Rajesh, and thanks for bringing it up that we should think when not to use gram-positive drugs rather than when to use because right now they are being used like left, right, and center. People are scared of using vancomycin, so they don't start it up front. But teicoplanin, they are very comfortable, so they keep using it all the time. There is a question related to, linezolid use in the ICU. That how do you make sure that um, monitor these patients? How do you watch out for serotonin syndrome? And what is your monitoring protocol for adverse effects?
Dr. Syed.
Yeah. You're muted, Dr. Simon.
Yeah, so for the linezolid syndrome, basically serotonin syndrome, we'll have to see for the onset of like after starting the linezolid within 24-48 hours, we'll be developing hypothermia and syndrome of increased tonicity of the muscles, increased hypertonia, and acute worsening of the syndrome. There is no typical like in case of properly taking history will be very much important of the patient whether the take because these drugs will have a level for like 7 to 14 days after stopping the SSRIs. So we'll have to take a proper history whether the patient was on. Very few cases we have seen patients who are overdosed or suicide attempt patients who get admitted and develop ventilator associated pneumonias or aspiration pneumonias. In those kind of cases, we'll have to be very much aware that we don't upfront use linezolid as a treatment for CAP.
So one important point is that I think you must do a drug interaction check. If you are prescribing linezolid in the ICU, like there are some drugs like an azole in the ICU, like whether it's voriconazole, fluconazole, and linezolid also belongs to that category. You must ask the ICU registrar to do a drug interaction check because if you don't do that, you might miss that interaction and you may get SSRI. So I think that is very important.
You know,
Yes, Dr. Chavla.
yeah, another very important thing is thrombocytopenia. Second day you find thrombocytopenia because of sepsis and you stop. It doesn't occur less than 5 days. And yes, the other things which we have seen sometimes, lactic acidosis. Suddenly, patient starts getting sick. When you do an ABG, the lactates are high and patient is acidotic. For a very prolonged use, we've seen few cases of optic neuritis, mainly in tuberculosis, when somebody is given BD dose rather than an OD dose. So these are the common side effect one should look for. The commonest, of course, is thrombocytopenia. It can occur after 5 to 7 days, but it is not that common because it's a basic disease causing and the linezolid is stopped. That's what I've seen.
And another side effect which I have seen is anemia.
Like
you
yes,
see it, you see that there is drop in hemoglobin, and many times we've actually had to stop it because of development of anemia and then painful peripheral neuropathy. So much pain that they have needed opioid analgesic. So that is also, of course, that's more with TB, but some of your patients with bone and joint infections who need it for a long time. And the other thing is the elderly people don't tolerate it. They have so much gastritis and anorexia that they just don't want to take the drug. They like recently we had a patient with VRE endocarditis who had progression of the disease despite being on daptomycin. So we added linezolid, and she could not tolerate the drug for 2 days. Just after 2 days, and we had to switch to tedizolid. So I think that is also a big problem with linezolid as far as tolerability is concerned.
So, what is your experience on tedizolid? I mean, this is a new drug. Most of the viewers might not have used this drug.
So I have been using it. Unfortunately, there's not much data about it because it's only being tested in skin and soft tissue infections for licensing. But we are increasingly using it as a substitute for non-tuberculous mycobacterial infections like M. abscessus, because we find that these patients need 6 or 12 months of therapy, so they don't tolerate linezolid, so we switch to tedizolid. There is no, it does not work for TB, so obviously you can't use it there. And also for bone and joint infections, where you have a patient, you can't give levonadiflox because you have MRSA, and you can't give levonadiflox because of the cost. The isolate is not susceptible to cotrimoxazole or clindamycin. Then we switch from linezolid to tedizolid, and patients have done well. They have not had relapses. So, bone and joint infections due to MRSA, second is M. abscessus infections, and the third is, like right now, it's been even evaluated in VRE endocarditis.
All right.
I mean, I'm just glancing through the, um, yeah, so people asked about Orita-vancin and dalbavancin. So, any experience with dalbavancin, Dr. Rohit or Dr. Sayan, any experience with use of these drugs?
So, I haven't used it. I had the opportunity to use it, but what the problem was that cost of dalbavancin of 1 week therapy is equivalent to 1 week of ticoplanin or vancomycin outpatient. So, patient never choose dalbavancin.
Now the cost has come down considerably. In the past 2 or 3 months, the cost has come down considerably of dalbavancin. So I think OPAT for endocarditis. We had a patient of Cons endocarditis, right-sided, where you could not switch to oral linezolid, is when we use dalbavancin weekly. And maybe that is a place where you can use it, because now where now you are having more and more evidence that many cases of endocarditis, bone and joint, you can switch to oral therapy. But if you have to continue parenteral therapy, then maybe, and the cost has come down, because earlier they had some stupid cost of some 30,000 for one vial. So that was too much. Now I think it is even available from the distributor at 10,000.
So, but it has to be given less. That also.
Yeah, that also is a factor. Like once a week. So especially in patients who don't have IV access, etc., is there is an issue, with that. And
even while treating for osteomyelitis as well, chronic osteomyelitis, we tend to get a lot of Redman syndrome or vancomycin flush syndromes. Those patients tend to get ticoplanin. Ticoplanin is still a opioid choice for these osteomyelitis patients if they need IV and then oral. But dalbavancin can be a
yes. So, but now we are tending to move towards oral therapy quickly in bone and joint.
Yeah.
If you have a highly bioavailable oral drug, you can switch to that. And another point which I wanted to make is in that patient of VRE endocarditis which you showed, which was pan resistant. Like, you showed that the isolate was even resistant to daptomycin, linezolid, and I think everything. It was even daptomycin resistant. You mentioned that we can use dapto, but I don't think you can use dapto in that patient. Of course, you have no choice. But did you do tigecycline susceptibility in that? Because we have had isolates of VRE which are resistant to everything, but they are tigecycline susceptible. So
yes,
that may be an option.
Yes, definitely. Daptomycin and whether high dose daptomycin with ceftaroline combination that can have some effect.
Yeah, but I think that's the problem with these patients. And I think the true PDR pathogen now is VRE. Because for the gram negatives, you still have some drugs.
Yes.
But for VRE, there are no drugs, and we have had isolates which are PDR, like pan drug resistant. So I think with that, Dr. Chawla, shall we wind up?
Yes, I think we can. And with that, I would like to thank Dr. Tarun Singhal for excellently not only moderating, given her experience on this subject, because we have all the three ID persons who have been treating these infections in their daily routine. And I'd also like to thank Dr. Rohit Kumar for giving a wonderful presentation. and Dr. Sayan Maharatnam. The original speaker had said the inability to take because of certain reason only a 1 week ago. And Dr. Sayan has prepared such a wonderful lecture.
Amazing lecture.
And very simple also for MRSA and PRA. Thank you very much. And for the persons which are more than 1,000, that this will be available for till next morning. So if you have missed the initial part, you can see these. And we'll meet next time. And from next time, with 3 modules, they are all on gram-negative infection in module 10. So see you next time. And also I'd like to thank Hexagon for conducting this very beautifully, and also Design Biosciences, which has supported this event. Thank you very much all the moderators, speakers, Dr. Akanksha, and see you next time at 7:30 p.m. next Tuesday, and that is 23rd. Thank you very much. Good night.
Thank you.
Good night, sir. Thank you.
Thank you, sir. Good night, everyone.
Thank you.